Today I will be discussing about the pharmacokinetics and the pharmacodynamics. Hope you enjoy. Pharmacokinetics and pharmacodynamics, rational dosing and time course of drug action. So first, what is pharmacokinetics? It is defined as a study of time course of drug absorption, distribution, metabolism, and excretion of drugs. So clinical pharmacokinetics is the application of pharmacokinetic principles to the safe and effective therapeutic management of drugs in an individual patient. So, there are four cornerstones of pharmacokinetics. First is absorption, distribution, metabolism, and elimination. So, drug concentration sites of action influenced by several factors such as route of administration, dose, and characteristics of drug molecules. An example for that is lipid solubility. So, in the route of drug administration, there's oral and inhalation such as vapors, gases, or smoke. So you can also absorb through mucous membranes, through intranasal or sniffing, sublingual, and rectal suppositories. You can also absorb them through injections like intravenous, intramuscular, subcutaneous, and intraperitoneal, which is only for non-humans. And you can also absorb them through transdermal. So here is the route of administration of drugs. So, the relationship between dose and effect can be separated into pharmacokinetic and pharmacodynamic. Pharmacokinetic dose concentration and pharmacodynamic concentration effect. So, components. Concentration provides the link between pharmacokinetics and pharmacodynamics and is the focus of the target concentration approach to the rational dosing. The three primary processes of pharmacokinetics are absorption, distribution, and elimination. As you can see right here in the picture, there are two different things. So, for the volume of distribution, relates to the amount of drug in the body to the concentration of drug in the blood or plasma. So volume, the formula of this, volume is equals to the amount of drug in the body and the concentration of drug in the blood or plasma. Drug plasma concentration, as you can see right here. So the volume of distribution may be defined with respect to blood, plasma, or water, unbound drug, depending on the concentration used in the equation. Drugs with very high volumes of distribution have much higher concentrations in extravascular tissue than in the vascular component. So they are not, examples are they are not having homogeneous distribution. So clearance, the formula of clearance first is clearance is rate of elimination plus drug blood plasma absorption. Concentration rather. So, drug clearance principles are similar to the clearance concepts of the renal physiology. Clearance of a drug is the factor that predicts the rate of elimination in relation to the drug concentration. Elimination of drug from the body may involve processes occurring in the kidney, the lung, the liver, and the other organs. Clearance like volume of distribution may be defined with respect of blood, plasma, or unbound water, depending on the concentration. Half-life is the time required to change the amount of drug in the body by 1/2 during elimination or during a constant infusion. The time course of drug in the body will depend on both the volume of distribution and the clearance. So the constant 0.7 in the equation is an approximation to the natural logarithm of 2. So half time is equals to 0.7 times volume divided by clearance. So life, solid line, plasma concentrations reflecting drug accumulation during a concentrate infusion of a drug. This one. So the dashed line, plasma concentrations reflecting drug elimination after a constant rate infusion of a drug that had reached a steady state. So this one is the plasma concentrations reflecting drug elimination. This is the plasma concentrations, drug accumulation, and drug elimination. So, half-life is useful because it indicates the time required to attain 50% of steady state or to decay 50% from steady state conditions after a change in the rate of drug administration. So, drug accumulation. Accumulation is inversely proportional to the fraction of the dose lost in each dosing interval. The fraction lost is 1 minus the fraction remaining just before the next dose. The fraction remaining can be predicted from the dosing interval and the half-life. So, accumulation factor is equals to 1 divided by the fraction lost in one dosing interval. And then it will then be 1 divided by 1 minus the fraction remaining, because you lost the fraction, so the fraction remaining. So the accumulation factor predicts the ratio of the steady state concentration to that seen in the same time following the first dose. So bioavailability, it refers to the rate and extent of absorption of a drug from dosage form. So, it is a measure of fraction of administered dose of a drug that reaches the systemic circulation in the underchanged form. So, availability, quantity of drug reaching the systemic circulation divided by the quantity of drug administered. So again, quantity of drug reaching the systemic circulation divided by quantity of drug administered. That is the bioavailability formula. So, extraction ratio and the first pass effect. So, systemic clearance is not affected by bioavailability. However, clearance can markedly affect the extent of availability because it determines the exact ratio. Drugs with high extraction ratios will show marked variations in bioavailability between subjects because of differences in hepatic function and blood flow. So, alternative routes of administration and first pass effect. There are several reasons for different routes of administration used in clinical medicine for the convenience. Examples are the oral, convenience to maximize concentration at the site of action and minimize it elsewhere. To prolong the process of drug absorption or to avoid the first pass effect. So there are several reasons for different routes used. And these are those that I mentioned. So the time course of drug effect. So immediate effects, drug are immediately related to observed drug concentration. Examples are in plasma. Delayed effects, drug effects are delayed in relation to observed drug concentration. And cumulative effects, drug effects are determined by the cumulative action of the drug. So, the time course of drug action combines the principle of pharmacokinetics and pharmacodynamics. As I have stated, pharmacokinetics describes the time course of the concentration, and pharmacodynamics affects with how effects change with concentration. So, the target concentration approach to designing a rational dosage regimen. So, a rational dosage regimen is based on the assumption that there is a target concentration that will produce the desired therapeutic effect. So, there is a maintenance dose and a loading dose. So, a maintenance dose, so it is the most important pharmacokinetic term to be considered in defining a rational steady drug dosage regimen. At steady state, the dosing rate in must equal to the rate of the elimination, rate out, substitution of the target concentration, Tc, and for concentration, C predicts the maintenance dosing rate. So, this is the one. The formula. Next is if the desired target is known, the clearance in that patient will determine the dosing rate. If the drug given by a route that has a bioavailability less than 100%, then the dosing rate is predicted by the last equation must be modified for oral dosing. So this is the one. Dosing rate for the oral, dosing rate divided by the rate. So, if intermittent doses are given, the maintenance dose is calculated form. So, maintenance dose is equal to the dosing rate times multiplied by the dosing interval. So, loading dose, the volume of distribution is a proportionality factor that relates the total amount of drug in the body to the concentration. If a loading dose is to achieve the target of concentration, then from the equation, loading dose is equal to the amount in the body immediately following the loading dose equals to volume times TC. The TC again is the target concentration. So, when intermittent doses are given, the loading dose calculated from the last equation will only reach the average steady state concentration and will not match the peak steady state concentration. To match the steady state concentration, the loading dose can be calculated from equation. So, loading dose is equal to maintenance dose multiplied by the accumulation factor if intermittent doses are given. So, pharmacokinetics variables, I apologize for the typo. Pharmacokinetic variables. So, absorption is the amount of drug that enters the body depends on the patient's adherence to the prescribed regimen and on the rate and extent of transfer from the site of administration to the blood. Clearance is the abnormal clearance may be anticipated when there is major impairment of the function of the kidney, liver, or heart. Volume of distribution. The apparent volume of distribution reflects a balance between binding to tissues, which decreases plasma concentration and makes the apparent volume larger, and binding to plasma proteins, which increases the plasma concentration and makes its apparent volume smaller. Half-life. The differences between the clearance and half-life are important in defining the underlying mechanisms for the effect of a disease state on drug disposition. So, interpretation of drug concentration measurements, clearance is the single most important factor determining drug concentrations. The interpretation of measurements of drug concentrations depends on a clear understanding of three factors that may influence the clearance, the dose, the organ, the blood flow, and the intrinsic function of the liver or kidneys. So, dosing history. An accurate dosing history is essential if one is to obtain maximum value from the drug concentration measurement. In fact, the dosing history is unknown or incomplete. A drug concentration measurement loses all predicted value. So, timing of samples or concentration measurement. Absorption usually occurs during the first 2 hours after a drug dose and varies according to the food intake, posture, and activity. Therefore, it is important to avoid drawing blood until absorption is complete about 2 hours after an oral dose. So, initial predictions of volume, distribution, and clearance. So, volume of distribution is commonly calculated for a particular patient using body weight. If a patient is obese, drugs that do not readily penetrate fat, examples are gentamicin and digoxin, should have their volumes calculated from a fat-free mass, as shown below, as shown on the side. Total body weight is in kilograms and height is in meters. So, for women, the formula is 37.99 for kilograms. Height in meters times weight, total body weight, divided by 35. That is the volume of distribution. And this is for men, as you can see. So, clearance, drugs cleared by the renal route often require adjustment of clearance in proportion to the renal function. This can be conveniently estimated from the creatinine clearance calculated from a single serum creatinine measurement and the predicted creatinine production rate. So, revising individual estimates of volume distribution and clearance. So, the common sense approach to the interpretation of drug concentrations compares predictions of pharmacokinetic parameters and expected concentrations to measured values. So if measured concentrations differ by more than 20% of predicted values, revised estimate volume or clearance for that patient should be calculated using volume of distribution equation or clearance equation as I discussed in the previous slides. So that is all. Thank you for watching. I hope that I have helped you learn about the pharmacokinetics and the pharmacodynamics. Have a great day.